Dean, oh, finally, at last. Now we hope that Dina may start introducing Joel. Dina.
Okay, thank you, Latha. Thank you, Alessandro. And welcome everybody for our webinar today. And I'm really very delighted to introduce Professor Joel Kopple. And the first time I met Professor Joel Kopple was many, many years ago, actually, and it was in the IFKF meeting in Mainz in Germany. And this was many years ago. And he was not just the father of the IFKF and the World Kidney Day, but he was the father of everyone, taking care of everyone and every detail since the day I met him. And actually, I will take a very long time introducing Professor Kopple. And Professor Kopple, he is an American professor, physician, clinical investigator in medicine, nephrology, nutrition, and public health. He's an emeritus professor at the David Geffen UCLA School of Medicine and the UCLA Fielding School of Public Health. He's also known as the father of the field of renal nutrition. Professor Koppel's research focus has been in amino acid, protein metabolism, and nutritional disorders and their management in kidney patients. He has authored and co-authored many hundreds of peer-reviewed manuscripts and invited papers and chapters. He's an editor of many proceedings and symposia and an editor of the textbook entitled Nutritional Management of Renal Disease. Professor Kopple has founded the International Society of Renal Nutrition and Metabolism, the International Federation of Kidney Foundation, the World Kidney Day, and served a central role in founding other institutions. He served as the president of the National Kidney Foundation, the American Society of Parenteral Nutrition, the ASPEN, and several other professional scientific societies. So we have all the pleasure to welcome Professor Kopple, who will be speaking to us today about the protein energy wasting in the chronic kidney disease patients. So does nutritional support affect clinical outcome in chronic kidney disease and end-stage renal disease patients? Professor Kopple.
Thank you very much, Dr. Abdellatif, and also Ms. Kumasarami and Professor Balducci. It's a real pleasure and a privilege to be here. I'd like to start with a case report. This is a 62-year-old woman who has been undergoing maintenance hemodialysis for 8 years and was admitted to the hospital with fever, chills, and a methicillin-sensitive Staphylococcus aureus bacteremia. She has a past history of diabetes mellitus for 25 years, hypertension, and peripheral vascular disease. She's a 30-pack-year smoker with symptomatic chronic obstructive pulmonary disease. The woman appears depressed and describes poor food intake, inadequate intake of protein, about 0.4 gram protein per kilogram per day, 15% high-quality protein, and calories, 10 kilocalories per kilogram per day, is confirmed by her dietitian. The patient describes an unintentional weight loss of 5 kilograms during the past 6 months. On examination, it turns out her body mass index is 20 kilogram per meter squared. Serum albumin is 2.8 grams per deciliter. Her pre-dialysis serum urea, nitrogen, and serum creatinine are 58 and 65. 2-hour postprandial serum glucose 140. LDL cholesterol is 160, not on lipid-lowering agents. And high sensitivity C-reactive protein, 10 milligram per deciliter. Her subjective global assessment score is 3. where 7 is very normal, very healthy, and 1 is the poorest. So some questions. Does this patient have protein energy malnutrition, protein energy wasting, both protein energy wasting and protein energy malnutrition, or neither protein energy wasting nor protein energy malnutrition? The next question is, what is the rationale for the selection that you make? Third question is nutritional support likely to clinically benefit this patient in terms of reducing protein energy wasting or malnutrition? And in terms of this patient's survival, will nutritional support, is it likely to have any effect? Which of the following maneuvers would you use to treat this patient? And list the order in which you would apply them. Dietary counseling, enteral nutrition, including tube feeding, food supplements, intradialytic parenteral nutrition, total parenteral nutrition. And this so let's start by asking the question, what is protein energy wasting? PEW is defined as the loss of somatic and circulating body protein and energy reserves. The term protein energy wasting is used rather than protein energy malnutrition because some causes of protein energy wasting are unrelated to inadequate nutrient intake. These would include, for example, losses of protein, the presence of inflammatory diseases, which cause a catabolic response with net protein degradation. So not every cause of wasting and loss of protein and energy reserves is due to inadequate intake. And this is the reason why this term protein energy wasting was introduced. Now, a consensus conference was held a number of years ago, and it was decided that for the diagnosis of protein energy wasting, at least 3 of the following 4 categories must be positive. Specific biochemical measurements, such as low serum albumin or prealbumin, also referred to as transthyretin, low body weight, reduced total body fat, or recent weight loss, a decrease in muscle mass, and low protein or energy intake. Specific measurements, as I mentioned, include serum albumin, transthyretin. Other measurements for diagnosing protein waste, energy wasting include subjective global assessment, the malnutrition inflammation score, the presence of inflammation is determined or indicated by high serum high sensitivity C-reactive protein, tumor necrosis factor alpha, interleukin-6, ferritin levels, skeletal muscle strength or function. For example, there can be reduced hand grip strength, decreased spontaneous gait speed, walking. Why are we so concerned about protein energy wasting? The reason is that it's associated with increased mortality. This slide shows the relative risk of death in the general population and in chronic hemodialysis patients according to the BMI of the individual. Now, if we focus first on the dark purple line, one sees that as the BMI increases, the risk of death rises rather substantially. People also with very low BMIs also have an increased death rate. But look at the difference in patients with protein energy wasting. The lower the BMI, the greater the risk of death. And as the BMI increases, even to levels of morbid obesity, the relative risk of death continues to fall. These data have been replicated in many studies. This is not an outlier study. but many studies show the same relationship. Very different, almost a mirror image of the normal relationship between body mass index and the relative risk of death. Not only this, but the effect of weight change over time on mortality has been shown to be quite positive. If we look at the triangle, the red line, which is the case mix adjusted for various clinical and demographic factors, including age, sex, and also the malnutrition inflammation score, one sees that as weight loss increases, as there's weight loss, the risk of a cardiovascular death goes up substantially. With weight gain, the risk of cardiovascular death actually falls below reference values. And furthermore, this is compared to people with no weight change. And furthermore, this is independent of the patient's baseline body weight. So even a obese individual who gains weight on chronic dialysis will tend to have less risk of cardiovascular death, while the person who loses weight, even somebody who's obese, will in fact have a greater risk of cardiovascular death. These data were obtained in almost 47,000 patients undergoing maintenance hemodialysis. Now, this is a study from, this is a study from Japan, which shows that people undergoing chronic dialysis in Japan with protein energy wasting, indicating by the very heavy line, have a much greater risk of death than do people with without protein energy wasting. Also, this is a study actually from Croatia, and in this study, the red color indicates a significantly negative association with survival, whereas the blue line indicates a significantly positive relationship. And one sees that age, visceral fat, waist circumference are all associated with reduced survival. The greater these values, for example, the greater the age, the greater the waist circumference, the greater the risk of death. And this is true in both chronic peritoneal dialysis patients as well as maintenance hemodialysis patients. On the other hand, those people who have increased hand grip strength, increase intracellular water, which is an indication of body cell mass, uric acid, fatty acid intake, sodium intake, and on BIA, bioelectrical impedance, increased phase angle, and increased serum albumin levels all have increased likelihood of survival. Now, why should sodium intake, uric acid, and fatty acid intake be associated with increased survival? Probably because these parameters are affected by appetite. And the greater the appetite, in general, the healthier the individual. We have published data previously that people with undergoing chronic hemodialysis who have anorexia or reduced appetite, as self-reported, have increased serum pro-inflammatory cytokines, including increased serum C-reactive protein. So high appetite is associated with less inflammatory markers, and that's probably why sodium intake, uric acid levels, and fatty acid intake are correlated with increased survival. Now, can can protein energy wasting be successfully treated? Well, there are a number of questions underlying this general question. And one is, will it improve their protein energy status? There are a very large number of clinical trials indicating that treatment of protein energy wasting with nutritional support improves nutritional status of both advanced CKD patients and patients undergoing maintenance dialysis. The evidence includes randomized prospective clinical trials, crossover studies, and 4 retrospective studies with matched controls. This is a list of randomized prospective control trials and the effect on nutritional status, and one sees that and these again are randomized prospective clinical trials. You can see that in comparison to the control groups, those that received nutritional support in general demonstrated increased body weight, body fat, lean body mass, sometimes increased arm muscle circumference, serum albumin and prealbumin transthyretin often increased. And one sees again a very commonly increase in albumin levels and body mass. Now, it's interesting. We know that serum albumin is strongly affected by inflammation, that it's a very sensitive marker of inflammation where the serum albumin levels fall. But here you see that notwithstanding that relationship, then in these randomized controlled trials, those that received nutritional support, in fact, demonstrated increase in the serum albumin levels. Now, these are more studies showing the same phenomenon, but also showing not only increase in nutritional factors, including again serum albumin, total protein, but also quality of life and with regard to mortality. We'll come to this in just a moment. Now, crossover trials show the same phenomena, that those who get, in fact, the treatment during their treatment arm of the crossover trials showed, again, increased nutritional status, body weight, arm circumference, normalization of many plasma amino acids, serum albumin levels often increased, decreased fibroblast growth factor 23, more positive nitrogen balance was shown in these studies as well. And now this is these data were taken from the Cochrane review by Bob Ma, in which he looked at the effect of serum albumin of nutritional support on serum albumin levels. And please note that the broken line here is shows an increase in serum albumin of about 0.2 gram per deciliter. This is the mean value. The average increase with these supplements in people who had protein energy wasting undergoing hemodialysis, the average increase was 0.2. And if you look at no increase at all, or a fall in serum albumin, only a small number of these clinical trials showed no increase or in fact, a decrease. Almost all showed some increase, and sometimes the rise in serum albumin levels was quite dramatic. Now, what about clinical outcomes? Will successful treatment of protein energy wasting improve clinical outcomes? Or is protein energy wasting essentially an epiphenomenon of superimposed diseases and aging, such as aging, dialysis treatment, etc., and the nutritional support has no effect, nor does the wasting have any effect on outcome? It's just an epiphenomena, a marker, if you will, of underlying serious diseases. So again, the question is protein energy wasting in itself a cause of the increased mortality, or is it just a marker of underlying diseases that increase fatality? And if you treat protein energy wasting, will that in itself improve clinical outcome? Well, these are data. First of all, there are no large-scale randomized prospective controlled trials. But what there are a number of large-scale trials, which include in which patients who received hemodialysis patients who received nutritional support were compared to people who didn't receive it, and in some studies, there were great effort was made to ensure that the two groups of patients were in fact similar clinically. In the very first study of this type, published by Glenn Chertow and colleagues almost 30 years ago now, 1,679 patients who received intradialytic parenteral nutrition were compared to over 22,000 patients who did not, and who were matched by age, sex, and a variety of clinical disorders. What Chertow and coworkers found that nutritional support was associated with greater survival in those with serum albumin of 3.3 gram per deciliter or lower. Kopple, in a much smaller study examining intradialytic parenteral nutrition, again showed increased survival in those who received nutritional support. Again, increased survival means statistically significantly increased survival. Some of these studies that compared were actually rather small in value. There was the study of Poole did not have a control group, so there's no data as to the effect on survival. Now, interestingly, in some of these studies, an oral nutritional supplement was given. For example, the study of Laxon and co-workers. And again, they demonstrated increased survival. Weiner and associates again gave a nutrition supplement with oral nutritional supplements during dialysis treatment and showed, again, statistically significant decrease in mortality. And finally, Perez and Torres, in the most recent study, treated, these are patients who were not undergoing dialysis. They were, they all had creatinine levels, as I'll come to, creatinine clearances measured less than 20 cc per minute per 1.73 meters squared. And one notices again that that there was significantly increased nutritional status, decreased hospitalization rates, and probably decreased mortality. The p-value here was, this is actually a typographical error, it's 0.051, not 0.51, but 0.051. And 25% of these people received oral nutritional supplements. The rest received very special dietary counseling. Now, let's go now back to these studies in more detail. And this is the first study by Chertow, in which maintenance hemodialysis patients were treated at National Medical Care, now Fresenius dialysis units, starting in January 1, 1991. I mentioned that 1,679 patients received IDPN at least once, and they were compared to over 22,000 patients who received no IDPN on December 31, 12 months later, or had died during the year. Home hemodialysis and chronic peritoneal dialysis patients were excluded. Baseline data were the mean values during the 6 months before January 1st, 1991 for the control patients, and values as close to the start of IDPN for the IDPN treated patients. The IDPN prescription duration and frequently, unfortunately, were unknown. The data were analyzed according to serum albumin and serum creatinine. and were adjusted for age, sex, race, the presence or absence of diabetes, and the type of kidney disease. Control and IDPN patients were followed for 1 year or until death. Now, in this retrospective unblinded study, IDPN was marginally associated with increased survival if serum albumin was 3.4 gram per deciliter or less, and p-value was 0.1. But it was strongly associated with increased survival if the serum albumin was 3.3 gram per deciliter or less, with a p-value of less than 0.01. At serum albumins of 3.5 gram per deciliter or greater, IDPN was actually associated with reduced survival, especially if the serum creatinine was greater than 8 milligrams per deciliter. Let me show you the data in this slide. And here, this outcomes were broken down according to whether the serum creatinine was 8 milligram per deciliter or greater, or greater than 8 milligram per deciliter, or 8 milligram per deciliter or less. And this shows the hazard of dying during the time of treatment. Now, again, if the serum albumin was 3.0 or less, there was a clear reduction in mortality in those who received IDPN. The pale bars are those who received IDPN. The darker bars are those the control patients. When the serum albumin was 3 to 3.5, in those with a creatinine of 8 or less, there was still a significant, as indicated by the black squares here, significant benefit. But when the serum albumin was 3.5 or greater, there was actually an increased risk of death in those that received IDPN. And you can see it for 3.5 to 4 or greater than 4. Now, what's the significance, one might ask, of breaking the patients down into those with creatinine of 8 or lower or greater than 8? Well, we know that people whose serum creatinine is greater than 8, first of all, have greater survival than those who have lower. These, again, are pre-dialysis values than those who have lower serum creatinine. Also, a higher creatinine is associated not only with increased skeletal muscle mass, which is an indication of health, but also with increased meat intake, striated muscle intake. And we know that, again, as I've mentioned earlier, appetite is a sign of health. It's associated with less circulating pro-inflammatory cytokines and less inflammation. One sees the same data here. This shows the odds ratio of death in the patients according to the serum albumin level. And if it's 3.0 or less, the serum albumin, a clear benefit in terms of reduction odds ratio of death. And this relationship continues of nutritional support, IDPN associated with reduced mortality, until one gets to a serum albumin of 3.4 gram per deciliter later. At this value, there's a trend, but not statistically significant. And when the serum albumin is 3.5 or less, there's absolutely no relationship between IDPN and survival. So IDPN in this study is only beneficial to those who have evidence of protein energy wasting. In summary, in this retrospective unblinded study, IDPN was marginally associated with increased survival if serum albumin was 3.4 gram per deciliter or lower, and was strongly associated with increased survival if serum albumin was 3.3 grams per deciliter or lower. At serum albumin levels of 3.5 gram per deciliter or greater, IDPN was associated with reduced survival, especially if serum creatinine was greater than 8 milligram per deciliter. Let's go now to the study by Kopple and Associates. In this study, 50 patients received IDPN in 31 patients who did not serve as controls. These were patients that were living in intensive care units largely, and 20 of the IDPN patients and statistically significant at the 0.01 by Cox analysis. This table shows the results, and with the total caseload, there's a 50 and 31%. There's a statistically significant difference, as I said, the less than 0.01 value of essentially 16.9 months till death in the treated group, and 7.5 months till death in the untreated group. That's the mean survival. When one breaks it down, one sees a trend similarly in both the diabetic patients and also in the non-diabetic patients, particularly strong in the diabetic patients. But the sample size, when you break it down, is so low that these values are not statistically significant. Well, I only mention the study because it's received a lot of attention. In this study, the FIND study of patients undergoing chronic dialysis, those who received IDPN indicated by the gray line had no difference in survival from those who did not receive IDPN. They both had similar levels of malnutrition, protein energy wasting. But there were several fundamental problems with this study. One was that all patients in both groups received oral nutritional supplements. So it was not just IDPN versus no IDPN. That was that all patients were already getting a nutritional treatment, nutritional support in the form of oral supplements. Also, the amount of IDPN given, the amount of nutrition, and also the amount of oral nutrition varied from center to center. So there was no clear understanding of the amount of nutritional support given to the people who did receive IDPN versus the people who did not. Now, this is an oral supplement from Alaxa and co-workers, and the aim of this study was to examine whether oral nutritional supplements will improve survival in maintenance hemodialysis patients with protein energy wasting. Some patients in the Fresenius Medical Care North America dialysis units who had serum albumins of 3.5 grams per deciliter or lower during the fourth quarter of 2009 were treated with oral nutritional supplements during hemodialysis treatments for 1 year. Again, this was given during that hemodialysis treatments or until the serum creatinine increased to 4 grams per deciliter or greater. Patients must not have received oral nutrition supplements during the 90 days prior to entering the study. Similarly, hemodialysis patients who did not receive oral nutritional supplement but had serum albumin of 3.5 grams per deciliter lower served as controls. So again, this is not a randomized controlled study. The patients were followed for 15 months. Patients were analyzed by intention to treat, where some controls actually did begin oral nutritional supplements after the cutoff date, and as treated where no control patients received, I'll call it ONS. And also were adjusted so that treated and control patients had similar baseline scores for factors that are likely to be associated with low serum albumin. So again, in the intention to treat, this must be emphasized, some patients actually did receive oral nutritional supplements, ONS, after the cutoff date. So what did they find? Well, of the 31,000 patients that were eligible, they found that they had 7,200 who received oral nutrition supplements, and about 21,000 who did not. In the as treated group, they compared 7,200 who received ONS to essentially 14,000 that did not. The patients were matched so that in the intention to treat, it was 5,200 in each group, and in the as treated group, there were 4,300 essentially in each group. Now this slide shows the this is the intention to treat group in those without a nutrition supplement, with nutritional supplement. And you can see that the survival actually was lower in those that did not get ONS initially on, but over a period of after several months, the data, the survivals became very similar. These values here are, in fact, are different. In the intention to treat, actually not intention to treat, in the actual as treated group, the B group, you can see there was in fact a significant difference with lower survival in those that did not receive treatment throughout. Now, again, I want to emphasize that in the intention to treat, we know that some of the control patients did receive ONS. So this slide shows the data in another way. This is the intention to treat patients, and this is unadjusted. This is adjusted for diabetes and significant other variables, and this is completely adjusted for all the variables. And one can see these little accent marks indicate that there's a significantly lower death rate in those receiving ONS, and after some adjustment, including for diabetes, and after full adjustment, significant reduction in mortality in those getting ONS. In the as treated group, where no patient who in the control received nutritional supplements, there was a much more dramatic reduction in mortality with in those that received ONS, much more dramatic as compared to the intention to treat. Now, if one examines the same data, but according to serum albumin, one sees that in intention to treat, if the serum albumin was 3.2 or lower, then there was a clear, highly significant reduction in mortality in those that received ONS. In contrast, when the serum albumin was 3.2 to 3.4 or 3.4 to 3.5, there was no difference in survival in those getting those assigned to not get ONS. But again, some of those assigned to not get ONS got it. If you look at actually those that were treated and did not get ONS, then those that were treated with ONS compared to those who did not get ONS, that whether the serum albumin was 3.2 or lower, 3.2, 3.4, or 3.4 to 3.5 or lower, one sees a highly statistically significant reduction in mortality in those with the nutrition who receive nutrition support. Now we go to another study, this one by Perez and Torres, that was just published 2 years ago. And in this study, 169 non-dialyzed advanced CKD patients were followed for 2 years. Creatinine clearances, these again were non-dialyzed patients, but creatinine clearances had to be less than 20 to be accepted into the study. Protein energy wasting was not necessarily present at the onset of the study. Now, 128 of these patients received very personalized nutrition. They enjoyed a nutrition education program where they were seen on 4 occasions by the same dietitian. And this dietitian designed a study that, a diet protocol which was designed for their specific needs according to whether they were obese or slender in terms of their energy intake, and that provided protein, a substantial amount of which was of high biological value. The patients were counseled on how to do cooking, how to select foods in the marketplace, and oral nutritional supplements were given to about 25% of these patients. 45 patients who did not receive did not participate in the nutrition education program served as controls. This slide shows the results with regard to nutritional status in those who received the nutrition education program. Again, 25% with oral nutrition supplements versus those who did not. And one sees that protein energy wasting at baseline fell by 6 months in those who received the nutrition education program plus oral nutrition supplements, but even with nutrition education program by itself, these data are both show significant reduction in protein energy wasting 6 months after these non-dialyzed CKD patients entered the program. Now this slide shows mortality rate, or if you turn it around, the survival, those that were still surviving after 24 months. In those that received participated in the nutrition education program up here in the green line, and those that did not, as indicated by the black line. And one sees that of those who received or participated in the nutrition education program, there was a substantially greater survival at 24 months. Now, so in conclusion from this study, maintenance from all of these studies, maintenance hemodialysis patients with serum albumin of 3.5 gram per deciliter lower has significantly greater 15-month survival when treated with ONS 3 times per week during dialysis. As treated analysis strengthened these findings. The limitations of the study is that it was not a randomized prospective trial, and there may have been unrecognized differences between the treated and untreated controls that might have affected the outcome. For example, the physicians prescribing the oral nutrition supplements may have been more diligent in their treatment of other aspects of the patient's medical conditions. It is possible some control patients were taking unreported nutrition supplements, however, and this would tend to actually diminish differences in outcome between the control and treatment groups. So the fact that some controls may have received nutritional supplements would make the highly significant differences that were found in the Laxon study even more impressive. With regard to the Weiner study, this is another study. Maintenance hemodialysis patients treated in dialysis clinics who had serum albumins of 3.5 gram per deciliter were offered a 15-gram oral protein supplement immediately before or during hemodialysis 3 times weekly. Patients could switch to another approved supplement if they desired. Supplements were stopped if serum albumin rose to 4 gram per deciliter or greater, and could be restarted if serum albumin fell again to less than 3.5 gram per deciliter or lower. All-cause mortality was compared in patients who started taking the supplement in September or October 2010 to patients who did not take the supplement. For this analysis, only hemodialysis patients who took the supplement and were treated in dialysis units were greater than 10% of the patients who prescribed the supplement were compared to patients who were not prescribed the supplement and who were dialyzed in units, where 10% of patients were prescribed the supplement. The importance of this was to show that was to increase the likelihood that patients who were taking the supplement that were assigned to take the supplement were in fact likely to take it. The primary outcome was all-cause mortality. Patients were censored at time of transplantation, changed in dialysis modality, or moved to a non-DCI dialysis unit. Mortality was ascertained through March 2012. This slide again shows the data in intention to treat. In the upper panel, and in the B panel, as treated. And one sees that there was a trend toward greater survival in those who received the nutrition support as compared to those that did not. And this difference was greater in those who actually received the support compared to those who didn't. One sees also that there was this shows the rise in serum albumin levels in those who received the nutrition support versus those that did not. And again, this difference was significant. And the difference is also shown in the as treated group, that those who received nutrition support tended to have greater survival, although the difference here was less than those, greater serum albumin than those that did not receive nutrition. Now, this is another trial from the DaVita dialysis centers in the United States. 3,300, almost 3,400 DaVita patients with serum albumin of 3.5 gram per deciliter or lower were prescribed ONS, and almost 3,400 propensity scored mass controlled hemodialysis patients were used for comparison. There was a 69% reduction in deaths with the oral nutrition supplement group with a hazard ratio of mortality of 0.31 and 33% fewer missed dialysis treatments versus controls. During follow-up, in the oral nutrition support treated group, serum albumin was lower, and the NPNA, the NPCR, and post-dialysis patients were higher compared to the control groups. And this study shows the proportion of patients who survived, and the broken line indicates those who received no oral nutritional supplement, and the solid black line shows that those that did, showing again less mortality in those that received the oral nutrition supplements. And these data, this shows the same data according to the mistreatment. Those that received oral nutrition supplements had less mistreatments. One has to say that one of the limitations in this study is that it's possible that those who received oral nutrition supplements were more motivated to come to dialysis treatments, and therefore, because they had fewer mistreatments, that this might have been a reason for the greater survival with the oral nutrition supplements. On the other hand, it's also possible that by getting oral nutrition supplements, the patients felt better and therefore were more likely to attend to the dialysis treatments. The study was not able to distinguish between these possibilities. So, in summary, protein energy wasting is common in non-dialyzed advanced CKD patients and in patients undergoing chronic dialysis. Although protein energy wasting has many causes, it is often treatable, especially with nutritional therapy. Although there are no randomized prospective control trials, 6 now, retrospective analysis involving relatively large numbers of hemodialysis patients have examined survival of hemodialysis patients who received either IDPN or oral nutrition supplements in comparison to hemodialysis patients who did not. In these studies, the nutritionally treated patients were matched to the control untreated patients using such methods as propensity scores. It's actually now 5 of the 6 patients showed a statistically significantly greater rise in serum albumin, and all 5 studies showed reduction in all-cause mortality in the hemodialysis patients with protein energy wasting who received nutritional support. So actually, all 6 studies. Because these were not randomized prospective controlled trials, conclusions regarding the value of nutritional therapy in these patients must be made with some caution. The risk of unidentified or identified confounders that may have biased results in these studies is not small. Perhaps one of the greatest potential confounders is that physicians who provided nutritional therapy to the patients may have been more aggressive or meticulous in other aspects of their treatment of their patients. And this greater attention to other aspects of their illnesses may have caused the patient's increased survival. Also, there may have been a publishing bias against studies that were negative or that showed worse outcomes in patients receiving nutritional support. Nonetheless, it is striking that 6 out of 6 studies indicated increased survival in hemodialysis patients with protein energy wasting who received nutritional therapy, and no large-scale studies showed no effect on survival or demonstrated reduced survival with nutritional therapy. Hence, it can be argued that advanced CKD patients and maintenance hemodialysis patients with protein energy wasting should receive nutritional therapy, at least until other studies, and particularly randomized prospective controlled clinical trials, indicate that this treatment is not helpful or is actually harmful. Again, there were some studies that showed that if the patients did not have substantial protein energy wasting, or at least a serum albumin of 3.4 or 3.3 gram per deciliter or lower, that nutritional support was not helpful and might have been harmful. So again, it's being recommended only for people who have evidence of protein energy wasting. Now, I'd like to take just a moment to talk about another aspect of nutritional support in the hemodialysis patients, and that's the value of eating during dialysis treatment. There are many parts. This is a very controversial question, and there are many parts of the world where patients will deliberately not be fed during dialysis because of the finding that there can be a postprandial decrease in blood pressure during hemodialysis with increased risk of symptomatic intradialytic hypotension, which is associated with increased mortality. Hypotension or risk of decreased blood pressure can lead to reduced hemodialysis dose because the nurses will cut down dialysis flow rate, the blood or the dialysate flow rates until, particularly dialysate flow rates, until the blood pressure returns to or close to baseline values. Of note is that eating 1 to 2 hours before starting hemodialysis provides nutrients to plasma without causing intradialytic hypotension at or just after the time that hemodialysis begins, depleting nutrients intracellularly. To say this a little differently, we know that gastric emptying is delayed in hemodialysis patients. And therefore, if one feeds the patient an hour or two before they begin dialysis, which is a time normally when during dialysis when the blood pressure tends to fall, you can give the nutrients which start to actually enter the bloodstream, much of which enter the bloodstream after the patient start dialysis treatment, and the risk of hypotension induced by the food should be lower. No randomized prospective trial has actually examined the long-term outcomes of oral feeding and dialysis, however. This slide summarizes the data from these studies, and you can see that many of these studies, there's a reduction in blood pressure that occurs postprandially after the patients eat, and the actually incidence of intradialytic hypotension is actually increased. It's not shown in all studies, but all studies tend to have a reduction in blood pressure. And you can see that it occurs early on, within 45 minutes of 2 hours of the onset of dialysis, which again could be an argument for feeding the patients before they start dialysis treatment, like an hour or two starting before. Now, in this regard, Connie Ree from Los Angeles and co-workers recently published the Freddie trial. In this study, 110 adult maintenance hemodialysis patients with serum albumins less than 4 were randomized to meals providing either 50 to 55 gram protein, 850 calories, 400 to 500 milligrams of phosphorus, and a phosphate binder, 0.5 to 1.5 grams of lanthanum carbonate, or to a meal composed of less than 1 gram protein, less than 50 calories, less than 20 milligrams of phosphorus, and phosphorus binders as needed. Meals were given during the first 60 minutes of each hemodialysis treatment for 8 weeks. So they received, since they were dialyzed 3 times a week, they received 24 meals, each of the patients. The key outcome was the increase in serum albumin of 0.2 gram per deciliter or greater, and a serum phosphorus that did not rise, but that remained between 3.5 and less than 5 milligram per deciliter. The results of the study, the results of the study showed that 27% of treatment group, 15 versus 15% of controls, attained the key outcome, and this is significant at the p less than 0.05. Also, serum interleukin-6 increased in 9% of the treatment groups versus 31% of the controls. And this was highly significant, p less than 0.00 or equal to 0.009. Serum parathyroid level, hormone levels at the end of study was 505 in the food supplement group versus 330 in the controls, and this was significantly different, these two values. There were no severe or non-severe adverse effects reported in either group. So my suggestion for a way of handling food intake in relation to hemodialysis is as follows. Gastric emptying is delayed in end-stage renal disease patients, especially during a hemodialysis session. An average of roughly 70 to 75% of an ingested mixed meal is still in the stomach after 2.25 hours of ingesting the meal, which indicates that perhaps the best time to feed the patient is before they begin dialysis. Therefore, I propose that patients should be fed a nutritious meal about 60 minutes before the onset of their hemodialysis session. This should reduce or prevent extracellular and intracellular depletion of amino acids during the hemodialysis session, which does happen routinely in patients who are hemodialyzed and do not eat during the dialysis, during or immediately before dialysis. So this should prevent or reduce amino acid depletion and promote protein synthesis during hemodialysis, as Kistler has shown, and also should reduce the risk of intradialytic hypotension. And I'd like to thank you very much for your kind attention to my presentation.
Thank you so much, Professor Kopple. Dina, would you like to, take everyone through the question and answers, please?
Thank you very much, Professor Kopple, for this very illustrative lecture. And I believe that we will need to hear more and more about the nutrition and nutrition in the kidney disease in the coming months. So to start with, because we have some questions that we will forward to you, but to start with, how far should the nephrologists be involved in the nutrition of the kidney patients?
Well, I'm of the opinion that it's essential. Let me say it a little differently. Our fellows, when they're learning to become nephrologists, are focused on the use of dialysis to remove toxins from the patient. they're looking at ways to remove it. They are aware that valuable nutrients are also removed by dialysis. But I keep pointing out to them that our job as nephrologists is not to just be concerned with what's removed, but also be concerned with what should be added to the patient. I'm interested in the word that's used is French word, the interior milieu of the patient and what actually is going on inside the patient's body. I'm not just concerned with what's being removed. I want to know what's going into the patient as well. If you want to make a person healthy, you're obviously going to be concerned not just by what's being lost or what's not being lost, but you want to know what's going into the patient. So in my opinion, you have to be concerned with the nutrient intake of a patient. There is no nephrologist, in my opinion, even those who deny any interest in nutrition, who doesn't spend some time on the nutritional management of the patient, if nothing else, with regard to their phosphorus intake and sodium and potassium intake. But it makes no sense not to be concerned about the intake of other nutrients, including their energy sources, the protein amino acid intake. So this is a long, to give the answer succinctly, I think a nephrologist is obligated to be concerned with the nutrition of their patients. And particularly because, as I just showed, that every study that's evaluated this, that has a control group, shows that when people develop protein energy wasting, that if you treat them with nutrition, you reduce their death rate. So how can a doctor not be interested in the patient's nutritional status if we know that wasting is associated with increased mortality, and that if you provide nutrition, you can reduce that mortality? I mean,
I totally agree. And maybe this is the message here, that all the nephrologists has to be so concerned about the nutrition of the kidney patients. And during the routine visits, this has to be assessed regularly. And the treatment is not one for all. And as you mentioned through your lecture, that even giving the supplements for those who do not need it might not be beneficial or might be a bit harmful for them. So the nutritional assessment and the wasting assessment should be a routine part of the patients in a nephrologist clinic. So maybe we can move on to some questions. And
should I open the questions here?
yeah.
Can you see the question and answer?
Well, would you like me to kind of read the question and then at least give my response?
As you like, okay. And
Oh,
also we have with us Professor Hani Hafiz from Egypt, from Professor of Nephrology in Cairo University. He wants to ask us something. And Professor Hani is currently the president of the AFRAN, the African Renal Association. And he's a professor in Cairo University, as he's been my professor and my mentor for more than 25 years. So, well, let's welcome Professor Hani, and I will try to allow him. Yeah. Professor Hani, are you with us? Hello? Maybe he's disconnected now. Okay. Professor Hani, are you with us?
I can tell you that when I joined, I had a little trouble too. So the professor may be having trouble.
Maybe we can start with the questions till we solve this this problem.
Would you like to read the question, Dina? Would you prefer that I do it?
Okay. Okay. So we've got a question here from Jude. If leptin, the appetite suppressing substance, gets cleared during dialysis, will it increase the appetite?
Well, first of all, I'm trying to remember what the molecular weight of leptin is, and I don't think it's very well cleared. I think it's the molecule is too large. But I can just tell you that experientially, patients don't describe a improvement in appetite immediately after a dialysis treatment, if that's what you're referring to. So immediately after dialysis, you don't see an improvement in appetite. On the other hand, there have been a number of studies that have looked at nutritional status during the first 6 to 12 months after starting hemodialysis. And in general, the protein energy status of the patient does improve. We actually, Dr. Rajneesh Mehrotra and I published on this, but so have a number of other people. And we showed increase in serum albumin level, often body weight increases. And I think the reason for this is that patients the vast majority of patients lose weight during the months before they start dialysis treatment. And I think they lose weight because they're quite uremic. The more uremic than the healthcare team recognizes. The patient himself or herself may not realize how uremic they are because it kind of often creeps up on them gradually in people with chronic kidney disease. And I've had many patients tell me after their first or second dialysis, they say, my God, I didn't realize how badly I felt before I started dialysis treatment. This is very typical. So in answer to the question, I think dialysis may not immediately improve appetite in somebody who's established on chronic dialysis, but dialysis does remove a number of toxins which are appetite suppressing. So your appetite may not improve after one dialysis it should be after each dialysis when you're already on dialysis treatment. But in general, appetite does improve in people after they start their chronic dialysis treatments. I hope that answers the question.
Okay. So Professor Hanya, are you with us now? Something wrong? Okay. So the next question is from Abdul Hamid, and he has 3 questions. He's asking about the protein intake in proteinuric and non-CKD patients, and the protein intake in hemodialysis and peritoneal dialysis patients, and the value of anti-inflammatory drugs like interleukin-1 and 6 blockers in such patients.
Well, if I let me start with the top question first. George Kaysen has shown very clearly that when a patient is proteinuric, particularly if it's nephrotic range proteinuria of 3 grams per day or more in the urine, but any proteinuric patient almost, that the more protein you eat, the more protein they lose in the urine. So if a person has, let's say, 400 milligrams per day of urinary protein, eating a high protein diet is not going to materially increase the urine protein. But if somebody puts out 4 or 5 grams a day and you eat, let's say, 80 or 100 grams of protein, 120 grams of protein, the end result, as published by George Kaysen, is that you'll excrete more protein in your urine and your serum protein does not actually increase. So what he recommends, and which I would support, is that in people who are proteinuric, is to use angiotensin receptor blockers or ACE inhibitors in order to suppress the proteinuria and also to reduce the rate of rise if one gives more protein. And what I'll do is I'll give the amount of protein that I think a patient will need if they're not proteinuric, for example, 0.6 to 0.8 grams protein per kilogram per day, and then I'll give them gram for gram additional protein up to roughly 5 grams of additional protein per day. So what does one do if a patient has 15, 20 grams, or let's say 10 to 15 grams of protein? I don't know whether the patient should receive how much increased protein they should receive. I think it's clear that they should be receiving an ACE inhibitor or an ARB, or maybe even a aldosterone receptor antagonist if they can tolerate that. But what do you do with a patient who excretes 20 or 30 grams or 35 grams of protein per day? Some of these people, I've actually ablated their kidneys. And the simplest way to do it is I've given them non-steroidal anti-inflammatory drugs like indomethacin, and that can actually cause anuria in some people with, let's say, a GFR of 4 or 5 cc per minute, who are excreting huge amounts of protein, near 25, 30 grams of protein per day. And this amount of protein loss actually can turn a patient into an invalid. So I don't think it's a small issue, but that's not the usual case. The usual amount of protein loss, obviously, we all know this, is less than that. And so I use a combination of a medicine that may suppress protein excretion in the urine, and I'll go up to maybe 5 grams or so above what I think is the patient's required intake if they didn't have proteinuria. With regard to the protein intake in maintenance hemodialysis and chronic dialysis patients, it was published about 2 years ago. The KDOQI revised guidelines came out with the new recommendations for dietary protein intake of non-dialyzed and dialyzed and transplanted people with kidney disease. And for maintenance hemodialysis and peritoneal dialysis patients, it runs, what they recommend is about 1.0 to 1.2 gram per kilogram per day, about closer to 1.2 if the patient is a diabetic. The KDIGO is coming out with some recommendations very shortly. They're actually, the comment period for those recommendations just ended. I can tell you that some of the recommendations are quite controversial, and people who are involved, nephrologists who are involved with the International Society for Renal Nutrition and Metabolism, actually have been critical of some of those recommendations. So whether those recommendations will be modified, I don't know. I just know that those criticisms were delivered and during the comment period, and we'll see I don't know what the end result will be yet, but those will be published probably in the next 1 to 4 months. Our anti-inflammatory and IL-6, IL-1 and 6 blockers of value. I think first of all, these IL-6 particularly, I think does many harmful things to the body. It causes, it's a catabolic agent. It causes anorexia, and I think if depending on the side effects of the anti-inflammatory drugs, I think it would be worth a trial of them. I'm not aware of any published data showing what the end results are. Maybe I've just missed that literature, and maybe somebody else on the panel would like to comment on that. I think theoretically, that's a very appropriate type of treatment, but whether it's been demonstrated yet to be clinically effective, I don't know. Now, why feeding during the first hour of dialysis? again, I think there are pros and cons. The pro, as I mentioned, if you look, and we've published extensively on this, if you look at if a person is fasting, if you look at the drop in plasma amino acid levels during dialysis, and if you look at the amount of amino acids removed during a hemodialysis treatment, it's very clear that much of the amino acids that are removed are coming from within the cell. They're not just coming from the extracellular space, because the drop in the plasma values cannot account for the amount of amino acids that are actually found in the dialysate if they're measured. And Alpa Kissler has shown very, very nicely that this loss is associated with a protein catabolic state. And that if you give a nutrition support either intravenously or orally during the dialysis treatment, you can reverse this. You can prevent the catabolic response, and the patient actually can be made anabolic actually during dialysis. He's published very nice papers on that. Now, given the high incidence of protein energy wasting, I think this is something that we can't ignore. So I'm of the opinion that people need to be fed around the time of dialysis. But as I said in my presentation, that given the fact that protein emptying from the stomach, that gastric emptying is delayed in almost all chronic dialysis patients, I'm of the opinion that and given the fact that intradialytic hypotension not rarely occurs if you feed the patient during dialysis, I'm of the opinion that we should be feeding the patient just before they go on dialysis, let's say an hour before, because most people who become hypotensive do it very shortly, usually within an hour or a little more than an hour after they eat. So if you feed them an hour, maybe an hour and a half before dialysis, they should not become hypotensive during dialysis. On the other hand, much of the nutrients that the patient eats are not going to be absorbed until the patient is on dialysis, because the stomach empties so much more slowly. So to me, this would be the best solution, is to feed the patient maybe an hour, hour and a quarter, hour and a half before they start dialysis treatment. Will this make a difference in terms of protein energy wasting? Well, as I mentioned, Connie Rhee, in a recent publication of the Freddy study, suggests that you'll end up with a higher serum albumin after 8 weeks. So this, in comparison to control patients. So this suggests that perhaps it is a very worthwhile endeavor. Anyone in the panel want to make any comments?
Dina, we have time for a couple more questions from Dr. Tarun and Dr. Mohammed. Okay.
And I see someone is raising hands.
Yeah. Dr. Tarun would like to know, first we'll go on to Dr. Mohammed's question. I think he has put it in the chat box.
Yeah. And okay.
Can you read it out?
He's with us. So
he's not able to come on, I think. Is he? Oh, he has come on now. Maybe he can
I see Dr. Professor Heifetz. How are you? How are you, sir? Well, I think you're mute. Maybe your mute is on.
We cannot hear you. Okay.
Okay. Maybe
Professor Henry was asking about the prevalence of frailty in the Western registries, the USRDS and the European.
The prevalence of,
the
prevalence of what?
Frailty. Frailty. Frail.
Oh, frailty.
Yeah.
Frailty, pardon me. Yes, I actually tended to stay away from that in this lecture. The prevalence of frailty is actually, it depends, first of all, on the age of the population, of the dialysis population. the older the dialysis population, the more common it is. Frailty actually was originally described by in the elderly people. It was originally gerontologists who actually addressed the question of frailty. And it's a very, very important question, because we know that people who are frail have a much higher mortality rate. In fact, and this is true not only of the elderly, it's also been shown very, very clearly now that this is also true in chronic dialysis, hemodialysis patients. And in fact, the latest study on this, involving between 900 and 1,000, I believe it were chronic dialysis, it was advanced CKD chronic dialysis patients, was just published in the last 2 or 3 or 4 weeks in by Marcello Tonelli from Canada. It just came out quite recently, and again showing that frailty is associated with a much higher mortality rate. Now, the question is, what can be done about it? Can you treat frailty? And if you treat it, does that change survival? First, it depends upon the cause of frailty. In my opinion, a major cause of it is the fact that people don't exercise regularly. I think that's true of everybody, not just CKD patients. And my own experience is that that once a CKD patient becomes frail, that your ability to reduce that frailty with exercise, that's assuming that all the comorbid conditions are more or less controlled. If they're diabetic, it's under relative good control. But if once a person becomes frail, if they've got any comorbid conditions, or just if they're very elderly, your ability to reverse that frailty is very limited. You can make progress, there's no question. And interestingly, in our experience, after just 2 or 3 exercise training sessions, a patient's exercise capacity begins to increase. But in terms of bringing a person back to normal, I think that's extremely unlikely, at least by the techniques that we know today. Maybe there are combinations of treatment that have not really been explored, for example, using exercise training plus a good protein energy intake, plus maybe giving people testosterone or insulin-like growth factor 1 or growth hormone, or some combination of these anabolic factors. Maybe that will do it. But the reason that I'm focusing on this is to say that the most important way to manage frailty is to prevent it with exercise training. And we need to put this on people's radar. I would just challenge everybody listening to this webinar, just ask yourself, how often, when you see a new CKD patient, how often do you discuss exercise training with that patient? I do it routinely, because that's a focus of mine. And incidentally, I've been exercising regularly since I was about 11 years old. But the issue is they need to build themselves up before they develop end-stage kidney failure. Incidentally, I'll tell you something else that I do with my CKD patients, particularly as they're approaching dialysis. I tell these people, if you're thinking of making a major investment or changing or starting a new business, talk to me before you do that. That I'm not qualified to decide whether it's a good business venture or not, but I am qualified to make a pretty good educated guess as to whether you will have the energy and the time to manage that investment. like off the walls, like something stupid. But if you talk with enough patients, I have seen patients who have invested heavy, they invested their life savings just before they ended up with end-stage kidney failure, and they could not manage the business. They lost everything. They lost their lives were essentially destroyed. First, they had to deal with dialysis treatment, and then on top of that, they had become impoverished because they had sunk all their money into a business which required their day-to-day attention. So if our job as healthcare workers is to relieve pain and suffering, then I think it's critical that we remember that people don't have our perspective. They'll make decisions unaware, perhaps, of how their forthcoming end-stage kidney failure is going to impact on their ability to manage new investments or new ventures. It's our job to at least advise them as to what their physical and emotional stamina is going to be over the forthcoming months, to the best of our ability. I've seen what happens when this doesn't happen. And I'll tell you something else too. This happens to some of the patients probably who are of doctors that are on this call. It's just the patients don't discuss this with the doctors. Patients are often afraid to talk about issues in their lives that they don't think are directly related to their health care. So we may be having, what I'm describing may be more common than is recognized because people don't talk about this to their doctors. Anyway, something to think about.
Yeah. And this was actually the second part of Professor Hani's question about the value of the gym and the sauna to improve the frailty and maybe improving the appetite of the patients.
So, Dina, we have time for one more question from Dr. Tarun, and then we'll wind up.
Well, I just have a couple who were raising their hands for a quite long time. So
I think that was done by mistake, actually.
So we have now Araso. So
I can answer this question by
Tarun.
Dr. Saha,
okay.
if I may. And that is, I think, people have not looked at the relationship between high serum CRP per se and the effect of nutritional supplements with regard to patient survival. But I can tell you this, that a very large proportion of people with protein energy wasting have elevated CRP values. And as I've said, study after study shows that nutritional support of these people does improve survival. So I would, and also raises serum albumin levels. And as you know, serum albumin is exquisitely sensitive to inflammation. Even minor amounts of inflammation will drop the albumin value in serum. And we've seen that giving nutritional support commonly, even in randomized prospective studies of people with protein energy wasting, serum albumin commonly increases in the group that received nutritional support. So I would contend that almost certainly I would think that at least some patients with elevated CRP can have improved survival with nutritional support. Yes.
So
Dina, we're running out of time. Can we finish with one question?
Do we still have more questions? I think we have answered all the questions here. So for those raising hands, do you want?
Well, I don't think, I think that was done by mistake. So maybe you could, conclude now, and then we can ask Dr. Alessandro to say a few words.
Okay, so I think now we can conclude this session, and thank you very much, Professor Kopple, for this very interesting and very important topic that you have given us the time and the chance to share it with us today. And actually, this is a very, very important topic that's usually overlooked by many nephrologists all over the world. And nutrition of the patients is important, and as the medications that they are prescribed. And we have to always emphasize on the importance to follow up wasting and follow up the nutrition of our patients regularly in our clinics. So thank you very much, and allow us to invite you more to our meetings, because we will always need you and need your support with us. And thank you for everyone who has been attending, and special thanks to Professor Hani Hafiz for joining us today. And we're very sorry that there is a problem with the voice, but we can see you clearly. And for Alessandro now.
I have a question, first of all, for Joel. What about the lab dosage about albumin? I mean, since you quoted from the different studies, the difference when you have an albumin of 3.2, 3.3, and then 3.5, but not to disperse or not to go over 4. So I think it's very important the dosage of albumin. There are different lab methods, with the bromocresol, green or blue, or with immunoassay. Can you hear me, Joel?
I can. Madeline, can you shut that door? Yeah, I can't hear. Go ahead, I can hear you now.
Okay, I start again. Now, I was worried about the lab method of dosage about albumin. Since there are different methods, and the result can move from one value to the other, and we had a very narrow limit. I mean, it must be, if it's 3.2, 3.3, and not 3.5, it's quite different. So we have different methods about with the bromocresol, immunoassay, and some others. So I would like to know your opinion about this. And then I have also a comment about the feeding in hemodialysis. You know very well that many years ago was strictly forbidden to eat during dialysis completely, due to the risk of nausea and vomiting and hypotension. And then things has changed, but it's changed because there's a public habit to encourage and to keep life better even during the dialysis session. I remember it was completely forbidden to watch the TV. Now everybody looks at his computer now during the hemodialysis, and eating the sandwich in the morning at probably the wrong time, because the administration decided to bring to the dialysis patient 11 o'clock in the morning to bring food or to bring sandwiches. So I think it's bad habit that should be opposite by the doctors. That's my opinion. And what about the albumin ratio and dosage?
Well, you raise a good question. To the best of my recollection, none of the studies that compared the response according to the patient's serum albumin described how albumin was measured. However, the standard way done in hospitals in the United States, and most of these studies came out of the United States. I think virtually all of them, well, not all, but most of them did, is using it's a dye binding method like bromocresol green or bromocresol purple. And the reason that those methods are used is because they're cheap and fast, as opposed to, for example, compared to, for example, nephelometry. So now, nephelometry measurements of albumin usually end up giving lower values than the same specimen would give using these dye binding methods. So what to do about this? I would just say that I guess one way is to just check the way albumin is measured in your lab. I would guess that probably in most parts of the world, it's dye binding when I say dye, it's DYE binding methods are still used, and they won't, even though different dyes are used, such as brome crystal green, brome crystal purple, that won't make much difference at all, if any. If you use nephelometry, then you might pick a slightly lower cutoff, maybe half instead of maybe 3.3 or lower, 3.4 or lower, maybe it would be 3.35 or 3.25 or lower. But I wouldn't make any more. That would be about the maximum of the adjustment that I would make, at least until there's more data available. But maybe I can ask you about Italy and Egypt. Is it usually, do you guys, do your hospitals use a dye binding method for measuring albumin?
In Italy, yes.
You know? Yeah.
Mostly the green bromocrystal.
Yeah. So these data would be, therefore, I think, completely applicable to your hospital labs.
Thank you. Well, thank you so much, Joel. It was a wonderful day. We are here since almost 2 hours, so that makes a very good result, and we hope to have you again on IFKF, since you were the founder of IFKF, very soon. Thank you to you and to everybody. Bye-bye.
I'd like to thank you as well. It was a privilege and an honor to give this talk, so thank you so much.
Thank you, Professor. Thank you, Dr. Alessandro. Thank you, Dina. Thank you, Kausalya, and Dr. Muruganathan Thangaraj, and everybody who has been part of this program, and all our viewers and participants and our attendees. Grateful thanks to all of you. Look out for more. We're going to have more on the kidney healthcare best practice approaches. So we want you all to be part of every program. Thank you.
Thank you, Lata.
Bye-bye.
Thank you. Bye-bye.
Good night and good morning and good afternoon, everybody.
Bye.
Bye-bye.
Good day.